Welcome to STRIPE, the Stroke Interprofessional Education Program. In this presentation, you will learn about the use of magnetic resonance imaging in stroke. My name is Surong and my colleague is Zain. We are from the Department of Neuroradiology, National Neuroscience Institute. The content for this presentation covers the following topics: a brief explanation of the magnetic resonance sequences used in stroke imaging, establishing the presence and age of infarcts, identifying large vessel pathology, assessing for hemorrhages, and a summary of the above. The 5 sequences currently used in MR stroke imaging are T2-weighted, diffusion-weighted imaging, magnetic resonance angiography, gradient echo, and fluid-attenuated inversion recovery. Each sequence is sensitive to different changes in the chemical environment of the brain and complement one another. The T2-weighted sequence is sensitive to the presence of water and fat in tissues. While it does not directly detect strokes, it is useful for detecting general pathologies, some of which mimic stroke symptoms. The diffusion-weighted sequence is highly sensitive to the speed of water diffusion. From this sequence, ADC map is generated. The ADC map can then quantify the diffusion speed. Magnetic resonance angiography is sensitive to fast-flowing blood within vessels. Gradient echo imaging is sensitive to the presence of iron found in hemoglobin. Fluid-attenuated inversion recovery is used to detect established edema. The total scan time for a typical MRI stroke sequence is about 15 minutes. Each additional sequence adds another 5 minutes. Not all patients are suitable candidates for MRI due to the presence of incompatible implants, clinical condition, or claustrophobia. We will now explore how MRI is used to diagnose the presence, age, and type of strokes.
DWI is the most sensitive sequence for detecting acute infarcts. Within minutes of arterial occlusion, ischemia leads to cytotoxic edema. Intracellular swelling causes restricted diffusion of water molecules. This region experiences less signal loss on the images and hence appears hyperintense or bright relative to surrounding tissue. The ADC map, which is automatically generated from the DWI sequence, shows the opposite effect. The region of restricted diffusion has a slower diffusion speed than surrounding tissue and hence appears hypointense or dark. A phenomenon known as T2 shine-through may occur, where a region may appear bright on DWI but not dark on ADC. This is due to other abnormalities and is not an acute infarct. Therefore, care must be taken to view both DWI and ADC together when assessing for stroke. The appearance of an infarct on DWI changes over time. Within the first week or so, DWI is bright while ADC is dark. In the subacute phase, or between 1 week to 1 month, cytotoxic edema starts to subside. DWI remains bright but slowly diminishes over time. Diffusion speed increases and ADC can appear almost normal. In chronic infarcts, gliosis sets in. Water now diffuses more freely compared to within surrounding tissue, and the greater signal loss leads to hypointensity on the DWI. The high diffusion values show up as hyperintensity on ADC. FLAIR appears as T2-weighted images, but signal from regions of water is suppressed and appear black. Tissue edema appears hyperintense, but usually only a few hours after onset. FLAIR is less sensitive compared to DWI for detecting infarcts. Thus, it is not routinely done. However, the utility of FLAIR comes in when the exact onset time is not known, such as in wake-up or unwitnessed strokes. If the infarct lesion is visible on DWI but not on FLAIR, it is called a DWI-FLAIR mismatch. This has been used as a surrogate marker for estimating the lesion age and can help determine the use of thrombolytic agent or reperfusion therapy. Infarcts may be caused by vessel occlusion or hemorrhage. we will now look at how MRI can differentiate between the two. Magnetic resonance angiography emphasizes contrast between flowing blood and stationary tissue. No contrast injection is required. The faster the blood flow, the brighter the signal on the images. Therefore, patent arteries appear bright, while stationary tissue appears dark gray. The images can then be processed into a three-dimensional view of the blood vessels without surrounding tissue in the way. This is very useful for assessing intracranial circulation and detecting vascular pathologies, such as occlusions, aneurysms, and arteriovenous malformations. Large artery occlusions appear as sudden signal cutoffs on the MRA, with lack of downstream perfusion. This could be due to an acute thrombus or worsening chronic stenosis. The brain tissue supplied by the artery is at risk of becoming infarcted, and a DWI can check for this. Patients with large artery occlusions may be candidates for reperfusion therapy. Gradient echo sequences are sensitive to the presence of iron in hemoglobin, which causes a sharp signal loss in the immediate area. Therefore, blood and vessels appear black. The larger the amount of hemoglobin, the further the signal loss extends. This is known as a blooming artifact, as the lesion may appear larger than its actual size. The gradient echo sequence cannot discern the age of the bleed. Chronic hemorrhages also appear as blooming artifacts on the scan, due to iron-rich hemosiderin staining. A CT scan can help differentiate between new and old bleeds. Bleeds may be caused by vascular pathologies, tumors, or trauma, and clinical history can narrow this down. An MRA may be useful to check for aneurysms or arteriovenous malformations if the pattern of bleeding is suspicious for vascular anomalies. A DWI may confirm the presence of a hemorrhagic infarct.
In summary, MRI is able to diagnose stroke from onset and differentiate between ischemic and hemorrhagic causes. To undergo MRI, patients must not have any incompatible implants and be able to keep still for the duration of the scan. DWI can detect an infarct within minutes of onset time. DWI images should always be viewed with the corresponding ADC. FLAIR is useful in wake-up and unwitnessed strokes, as a DWI-FLAIR mismatch may act as a surrogate marker for onset time. MRA can assess intracranial circulation and identify large vessel occlusions as well as other vascular anomalies. Bleeds are visible on GRE, but the age of the bleed may be indeterminate. Thank you for listening to our presentation. We hope you have found it helpful. Please continue to explore Stripe for more stroke interprofessional education resources.